welcome in the first session of Oncology Conference. This session will be concerned with thoracic surgery. We have three speakers. The first speaker, Dr. Iri Fadel. His topic is titled Autologous Tracheal Reconstruction.
Thank you. Thank you, dear Chairman, ladies and gentlemen. So it's a real honor for me to be here in Cairo with you for this meeting in this wonderful city. Talk about tracheal reconstruction. Nothing to disclose. So, extensive tracheal replacement remains one of the greatest challenges in thoracic surgery when direct end-to-end anastomosis is impossible or has failed. The main indication for this surgery is primary tracheal replacement, neoplasma, adenomycystic carcinoma or squamous cell carcinoma, involvement of the trachea by the thyroid cancer, extensive tracheoesophageal fistula, or unsuccessful previous surgery for benign disease of the trachea. This surgery is required when the length of trachea resected is greater than 50% in adults, so it's about 6 centimeters, or 30% in children. The main characteristic of an ideal tracheal substitute, as has been defined by Hermes Grillo in 2002, is a lateral rigidity and stiffness to avoid collapse during breath, longitudinal flexibility to allow movement of the neck, airtight lumen to avoid infections, no need for immunosuppressor to avoid infections. It should be surgery reliable, feasible, and reproducible, and with biocompatible tissues to low integration to adjacent tissues. So you should avoid chronic inflammation, granulation, tissue, infection, and erosion. The available techniques published for tracheal replacements use synthetic materials. All of them has failed because of infection. Allograft, aortic allograft, but aortic allograft requires the use of a stent because of the collapse of the aorta. Partial tracheal allograft with a lot of risk of necrosis of this allograft because there is no blood supply. Tracheal transplantations used into the forearms had been published very recently. We will describe our technique of autologous tissue composite and bioengineering replacement with into a bioreactor and with a stem cell used. However, research on stem cells sparked much interest and was thought to be a revolutionary technique. However, the poor long-term results of this technique highlight there is a long way to go before successful use. And currently, only autologous tissue composite with or without tracheal allograft is the only long-term working solution for all etiologies, and despite complexity of this surgery. So let's go to our technique that we have developed in the 20 years ago. We use a fasciocutaneous forearm flap vascularized by the radial pedicle, artery and vein, and this fasciocutaneous flap is reinforced by cartilage with a slice of cartilage used every 1 centimeter, and we will construct like a tube, like a tracheal tube, like as you can see here, vascularized with the pedicle. How we do? We start by doing this forearm flap, fasciocutaneous flap, and this flap is reinforced by this cartilage that we remove from this part of the chest, the cartilage of the lower ribs here, and we cut slices 1 millimeter thickness, and that we use it, and here these slides are inserted here every 1 centimeter to reinforce this trachea, this new trachea, and we keep it vascularized with the pedicle here, as you can see here. And as soon as you have finished the resection of the tumor or of the trachea, the flap is moved and to the neck. Here, this is a case of a 59 years old woman with a adenomocystic carcinoma, as you can see here, involved of the trachea. All the trachea was involved. And you see here is the bronchoscopy, pre-operative bronchoscopy with complete obstruction of the trachea. This tumor had been resected and replaced by this flap. And you see here the control 1 month after the surgery. This is the beginning of the upper part of the trachea, and then enter the neotrachea. And you see that the lumen is open, and we have all suppressions here. This is the anastomosis. 1 month after the surgery. No more stent inside. So here we do this is the neotrachea with the vascularized into the artery is reimplanted into laterally to the right carotid artery or the left carotid artery, and the vein into the jugular vein, homolateral jugular vein. Here you see the anastomosis. It's a microsurgical anastomosis, and you see here the neotrachea. The neck, the head is here, and the thorax is here, and you see this view with the anastomosis. So this is 1 year follow-up of the same patient. You see here inside of the neotrachea we have a lot of sputum that we have to clean with the bronchoscope, and you see some hair because it's a forearm hair. And you see the CT scan control of this ribs. This cartilage ribs here. You see that on the CT scan. And the forearm is closed with a skin graft. We can also use it for partial resection of the trachea and partial resection of the esophagus for a tumor involving the trachea and the esophagus. So we use this flap, armored flap, and the remaining flap is used to close the esophagus. This is a case of a young man, 20 years old, with a sarcoma of the trachea involving part of the trachea, as you can see here on the CT scan, and the part of the esophagus. He was referred with a stent. So the tumor is here. So we resected, fully resected here. This is the trachea. And the tumor is removed. Of course, we do a frozen section to ensure that we are in disease-free margins. This is the tumor. So we use the partial part of the flap armed with the cartilage to reconstruct the trachea, and the other partial part of the flap to close the esophagus. And here you have the control 1 week after the surgery of the trachea. It's still completely open without any stent. And you have this sputum that you clean on a bronchoscopy. And you see here the hair from the skin. We also can use it without the need of by cartilage, because in patients with a large tracheoesophageal fistula, so this patient had a destroyed trachea, and they used after radiation therapy, they put a stent into the trachea, another stent into the esophagus. When he was referred, he had a huge fistula between the trachea and the esophagus. So we used a non-armored flap, forearm flap, to close both the membranes of the trachea and the esophagus. So the post-operative care of those patients, all of them should be put on antibiotics. We keep them with a silicone stent for 1 or 2 weeks to remodel of the neotrachea. Of course, we do a temporary tracheostomy to clean, to repeat a bronchoscopy to clean the trachea once or twice a day, with aerosol therapy every day and additional radiation therapy when it's required for a tumor. We published that first we did this study in the beginning. We developed this model, an animal model, large animal models, and then published that, and we published our earlier series of patients in 2013, and we reviewed that very recently, and we published the case in the New England Journal of a young child who also required this resection of the trachea, complete resection of the trachea. So since 2004, our experience is now about of 28 patients with a mean age of 51, ranging from 12 years as the child to 75 years old. The main indication were tumor, tracheal tumor, adenomyocystic carcinoma, tracheal carcinoma, sarcoma, a thyroid cancer involving the trachea in 5 patients, and the remaining patients are large tracheoesophageal fistula in 3 patients, or large tracheal destruction after former surgery in 4 patients. And the esophagus was resected in 8 patients of them. 1 patient required a pneumonectomy, and all 22% of those 22 patients among the 28 required the use of cardiopulmonary bypass during the procedure. We achieved R0 resection in 14 patients and R1 resection in 7 patients. You know that for adenomyocystic carcinoma, even if you have R1 resection, it's not completely pejorative, because they have a similar survival if you give them postoperative radiation therapy than R0 resection. So the extent of resection was in 12 patients a complete tracheal replacement, complete tracheal resection. In 3 patients, complete tracheal resection extended to both main bronchi. In 8 patients, it was a tracheal resection extended to the larynx because of a tumor involved in the vocal cord and over that. In 2 patients, it was a partial resection of the trachea and the esophagus, and in 3 patients, a large fistula between the esophagus and the trachea. So here you see the postoperative complication. A very important morbidity rate, 46%, because some of thrombosis of the anastomosis of the vein or of the artery. The major complication is the pneumonia with ARDS, as you can see here. 5 patients had developed this complication, 2 of them died. Mediastinitis in 2 patients, stroke in 1 patient who died, and heart failure in one other patient. So our operative mortality rate is very, very high, 14%, but a very good overall survival. 5-year survival is 56%, and 10-year survival 41%. All of them are free of any stenting into the neotrachea. So in conclusion, autologous tracheal reconstruction with fasciocutaneous free flaps reinforced by costal cartilage is a reliable procedure with nearly all qualities of the ideal tracheal substitute: well vascularized, resistant to infection, rigid enough to resist to respiratory pressure variations, extensive tracheal disease previously not amenable to tracheal replacement can now be successfully managed with this technique. Of course, transitory tracheostomy and repeated bronchoscopy are mandatory postoperatively because of the absence of mucociliary clearance. Thank you for your attention.
Thanks, Professor Eli Fadil. And we invite the second speaker, Robert Tijor, for early detection of lung cancer and the management of incidental pulmonary edema.
Chairpersons, ladies and gentlemen, I'm honored to be here, and I would like to thank the Society for inviting me to talk to you today about early detection of lung cancer, screening and management of incidental pulmonary nodule from a surgeon's perspective. As we're all aware, lung cancer is the most common cancer among men in terms of both incidence and mortality, and among women it has the 3rd highest incidence and is known to be the 2nd cause of mortality after breast cancer. Overall, it represents approximately 20% of cancer death. The highest rates are North America, Europe, East Asia, and rates in Africa, Middle East, and South Asia are much lower, but maybe this is possible to underdiagnosis. In the US, the lifetime risk of developing lung cancer is 8% in men and approximately 6% in women. This is an interesting figure that I came across, that for every 3 to 4 million cigarettes smoked, 1 lung cancer death can occur. And how do we prevent lung cancer? How can we cure these patients? Except for smoking cessation, perhaps the second highest reduction in lung cancer mortality rate is related to early diagnosis followed by surgical resection. Over the past 50 years, when it was first published in 1971, only 7% of patients with lung cancer were cured. Now, 50 years later, or almost 50 years later, only 15% are still cured, despite the fact that we have advancement in radiotherapy, chemotherapy, we've introduced targeted molecular therapy, chemotherapy as well, immunotherapy, and of course advancement in surgical techniques. But the only change was double the cure rate, where we can go better, where we can do more. This rationale for any lung cancer screening program is, first one depends on smoking cessation, which I understand in places in the Middle East can be very difficult. But smoking cessation helps, and this is a very interesting study by Pito in 2000 that was published in BMJ, showing that patients who have smoked for until the age of 75 have a cumulative risk of death from lung cancer by 16% compared to those who don't smoke, which is less than 0.5%. However, if you stop smoking between the age of 30 to the age of 60, this risk of death from lung cancer decreases by age. The second important component to minimize lung cancer death or screening from lung cancer is to improve survival by early stage disease, diagnosing early stage disease. So overall, 5-year survival of all lung cancers is 15%. If you resect clinical stage 1, the 5-year survival ranges between 75 to 92%, depends on the study that you look at. Let me take you through some current data from chest x-rays and CT screening studies. Some of these are old, but they were the cornerstone and the foundation of where we are now from cancer screening programs. The first trial was identified by Mayo Lung Cancer Screening Project, where they enrolled 9,000 patients and they screened for just more than 4,500 patients with chest x-rays and pooled sputum, and the others were the usual care group. 206 lung cancer patients were identified in this group compared to 160 in that group, this representing 40% and 25%. By looking at detection of the rate of lung cancer was 8.3 per 1,000 screens of male smoker. And if you look at the survival probability and the death, there was no significant difference. Yet, those who had the chest x-ray and pooled sputum analysis had slightly improved outcomes. The interpretation of this study was overdiagnosis, and chest x-ray is not effective in reducing mortality. Also, there were certain problems with this study. Underpowered, and there was significant contamination and compliance. And this has led to the development of the PLCO trial, which was launched, and that was published in 2005 and stands for the Prostate, Lung, Colorectal and Ovarian Cancer Screening Trial. This was a randomized control trial looking at 150,000 patients, 1-to-1 randomization of chest x-ray screening versus no screening. Again, the detection rate of lung cancer was only 8 per 1,000 compared to 8.3 in the Mayo Lung Project. And the conclusion was they're not sufficient to confirm effectiveness of chest x-ray on lung cancer mortality. So where do we go now? We have been using low-dose helical CT scan, and this allows the entire chest to be surveyed in a single breath hold. Very rapid, 7 to 15 seconds, that's how long it takes. Reduces motion artifact, narrow slice, and you can perform 4 patients per hour for this. And also the radiation dose is 1/10 of a diagnostic CT scan. What do we see on the CT scan? Three components. We can see ground cloud opacity, or mixed opacity, or solid opacity. The Mayo Clinic helical CT study, which was published in the early 2000s, they looked at 1,520 individuals, and they concluded that CT can depict early stage lung cancer, but the rate of benign nodule detection is high. The same group have followed their same patients and for 5 years, and they have concluded that CT allows detection of early stage lung cancers, but benign nodule detection was also high, suggesting no stage shift. This has led to the development of the International Early Lung Cancer Action Program, which is the ILCAP. This was a prospective international multi-institutional observational trial where they have observed 31,567 patients with a high risk of lung cancer. They've done the scans twice, at baseline and a year later. At baseline, they identified 410 lung cancers, and a year later, they identified an additional 74. The total lung cancers was 484, and out of these, 535 biopsies with a positive rate of 90%. 85% were clinical stage 1. They've concluded that those who had stage 1 lung cancer for 10 years mortality or survival was significantly higher than all lung cancer patients, 92% versus 80%. The lesson that was from this CT observational trial was that detected prevalence rate is 0.4 to 2.7%, nodule detection is 5 to 50%, and CT results in higher lung cancer detection than chest X-ray, 3 times higher than chest X-ray, but also there was no stage shift. Finally, the National Lung Screening Trial Research Team, the NLST, have come up with their trial, which was a randomization of 53,000 patients with CT versus chest X-ray, and they've done the scans for the intervention at 3 time points, time 0, 1 year, and 2 years. Excellent compliance for such a large study with such a population. And they've identified that those who have a CT scan compared to chest X-ray have a higher and improved cumulative risk of lung cancer detection, and also the death from mortality for those who had a CT scan versus chest X-ray was 20% lower in the CT group. There were some drawbacks with this study, 25% overdiagnosis and concerns of repeat imaging and exposure. Finally, just before going to the second part of what to do with the incidental pulmonary nodule, is the breath test. This is in its infancy still, and there are many institutions and national health services have allocated significant funding to identify and optimize this technique as a fast protocol to assess patients with lung cancer. It remains very suboptimal, but still promising in the future. So what do we do when we identify a lung nodule? What we do is radiation carcinogenesis, that's how I call it, which is CT PET scan. Following by that, we do biopsies, bronchoscopies, VATs, thoracotomies needed for benign diseases, and then we also get involved in evaluation of other observations, such as cardiac, renal, liver, or adrenal diseases. So just a quick summary for the screening part. The most effective way to reduce smoking-related disease is to stop smoking. Observational studies have shown that CT screening indicates a high rate of stage 1 lung cancer, and intervention can result from screening at economic, emotional, and medical cost. CT screening reveals many non-classified nodules, the majority of which will be benign. So what do we do with the solitary pulmonary nodule, and how do we define that? Most of you are respiratory physicians, and you do better than me by defining this. So in a simple word, it's single round discrete pulmonary opacity, measuring more than 3 centimeters in diameter, surrounded by lung tissue and not associated with adenopathy or atelectasis. So as a surgeon, what do we do? Is it a nodule? Is it benign or malignant? Should it be investigated? Should it be observed? Should we surgically resect it? Most solitary nodules have a benign cause. They can be benign like healed granuloma, or most also recent studies have shown higher percentage of malignancy among resected nodules than do older studies. And this is most likely related to improved diagnostic techniques such as CT and PET. So factors affecting the likelihood of malignancy: age, history of smoking, presence of other malignancies, and the characteristics of lesion. So it's well recognized that as we increase patients' age, the risk of this lesion being malignant increases. And a study in 1983 showed that patients 50 years old and above, if they have a nodule, 65% of this is malignant. If they're less than 50, its possibility of it being malignant is 35%. But we have to be very cautious, as young persons doesn't mean young persons will only have a benign disease. Also, history of smoking, strong association of cigarette smoking with primary lung cancer, as we're all aware. And previously diagnosed malignancies increase the likelihood that SPN might represent metastatic disease. Characteristics of a lesion. If the lesion size is less than 1 centimeter, we accept that it's only 25 to 35% is malignant, and more than 80% of lesion over 5 centimeters are malignant. Although gross weight and calcification act as important factors in determining whether a nodule is cancerous or malignant or not. This is the British Thoracic Society guidelines of how to cope with how to analyze a solid, non-calcified lesion on a CT scan. If it has clear features of benign disease and less than 5 millimeter or less than 80 millimeter in volume, we discharge the patients. If it's not, we look for previous imaging if there is any. If there are none, we start working them up and we go either CT surveillance or we consider biopsy and excision or non-surgical treatment. The surveillance all depends on the size of the nodule. If it's between 5 to 6 millimeter in diameter or more than 80 millimeter or more than 6 millimeter in diameter. If it's 5 to 6 millimeter, we do CT scan at 1 year base, and if it's more than 6 millimeter, then we look at the doubling time. And then again, we either continue monitoring the patients and repeat their scans at 2 years after baseline, discharge them, or consider further investigation. What is if it is subsolid nodule, like a part solid nodule? If it's less than 5 millimeter, we discharge the patient. And especially if it's been stable for 4 years or patient been unfit for treatment. If they had previous imaging, then we assess if there has been change. If there is any growth or altered morphology, we favor resections. Of course, all these discussions take place in multidisciplinary team with the pulmonologists, physicians, as well as radiologists and histopathologists. To diagnose an SPN, the best approach is percutaneous needle biopsy, with good 64-97% malignancy, diagnosed malignancy and accuracy reaching 80%. PET-CT has sensitivity of approaching 95% and specificity over 85%. VATS excision biopsy is safe, highly effective. Smaller lesions, however, can be difficult to identify. Recently, I have been using personally hook wire localization, and the problem with this, of course, is displacement and minor pneumothorax. So the patient goes to CT room, a hook wire is inserted, and then they get transferred to the operating room whilst intubated, and then we proceed to the VATS resection. Although this helps localizing the lesion, but the most important complication we find is displacement and parenchymal hemorrhage. Another approach is dye localization. One problem with dye localization is rapid diffusion of the dye. By the time we're inside the chest, the dye has disappeared. Recently, navigation bronchoscopy has come into play, into the game as well, which is a very safe and effective technique, and we can localize multiple lung nodules at the same time. So decision-making process is MDT related, multidisciplinary team, patient involvement to decide between follow-up and surgery with our recommendations, and decisions if influenced by numerous factors. Probability of nodule being malignant, risks of surgery, accuracy of biopsy, and also surgeon's confidence in making a decision. So do we wait or watch, or immediate surgery or non-surgical treatment? Again, this depends on the patient, but we advise for resection, for wait and watch where risks of malignancy is low, risk of surgery are high, and patient refuses further investigations or procedures. So treatment algorithm that I follow is excision or non-surgical treatment considered. We do PET staging for CT scan, and if they're fit for surgery, we choose between anatomical segmentectomy or lobectomy. If they're unfit for surgery, we proceed with lung biopsy, and then we go down the oncological route. So this is just a summary of how do we approach solitary pulmonary nodule. If a new nodule is identified, we work it down to either follow-up CT scans or additional investigation or a VATS resection and proceed accordingly. So in conclusion, there is no way to manage indeterminate nodule, but diagnosis requires a suitable clinical evaluation. The judicious application of diagnostic methods that based on medicine evidence base will improve the quality of medical attention. Excision biopsy may be attractive for the surgeon because it provides definite diagnosis, and it's also important to assess and respect the patient's anxiety and fears. Thank you very much.
Thank you, Dr. Robert, for illustrating this important issue of early detection of lung cancer. And if there is any question? So we introduce the next speaker, Professor Dr. Ahmed Al-Nouri. His topic will be about the management of oligometastatic non-small cell lung cancer.
Dear Chairman, thank you for the invitation. Today I'm going to talk about the role of surgery in oligometastatic non-small cell lung cancer. The non-small cell lung cancer remains the leading cause of death, the leading cause of cancer-related mortality. The majority of lung cancer patients are diagnosed with advanced stage disease which carries a particularly poor prognosis with few long-term survivors. Median overall 5-year survival rate of non-small cell lung cancer is about 18% and substantially lower in stage 4 patients, ranging between 4 to 6%. The standard treatment rely on complex multidisciplinary regimens, which typically include cytotoxic chemotherapy, frequently in combination with palliative irradiation, as well as targeted and immunotherapy. Traditionally, the stage 4 treatment remains. Regimens have not included curative intent surgical treatment. Therapeutic goals focus on disease control, optimization of quality of life, and palliation. This is the 5-year survival, and we can see that the stage 4 5-year survival is around 5%. In 2017, there was another update in the TNM staging system, which reclassified the metastatic disease into A, B, and C, M1A, M1B, and M1C. A is a separate nodule in the contralateral lung, or tumor with pleural or precardial nodules, or malignant pleural or precardial effusion. B is the single extrathoracic metastasis in a single organ, and C is the multi-extrathoracic metastasis. And based on this heterogeneity of this group, the median survival differs significantly between 22 months in M1A down to 13 months in M1C. So these patients are not the same. Although they are the same in the stage 4, but probably the survival will be different between. Again, these are not the same and the behavior will be different. So, it's becoming increasingly clear that patients with metastatic lung cancer are heterogeneous group, despite all being characterized as stage 4. The oligometastatic lung cancer is a subset group of patients in stage 4. It is a disease with low metastatic burden and limited organ involvement. It is conceived as an intermediate condition between truly localized disease and a widely metastatic tumor. This word, oligometastatic, appeared for the first time in 1995 by Herman and Weichelbaum, who proposed the existence of a clinically significant state of oligometastasis. The oligometastasis is a usable term now by which we identify a subset of patients in group 4 who have disseminated cancer, but to a limited area, so their prognosis is better than the typical stage 4 patients. Oligometastases are mostly defined as maximum 5 metastatic lesions on the body, although the clear definition was different between school and another, but all the schools decided that the figure 5 is the cut limit between disseminated metastasis and oligometastasis, which can be either synchronous when diagnosed within 1 month before or after the primary tumor was identified, or metachronous when they appear after the treatment of the primary. And because of the lack of the prospective data, it's not clear if some anatomical locations of the metastasis have a worse prognosis than others. Again, it is not clear whether the biology of the disease or the local therapy influences the survival. The radical local therapy with either surgery or high-dose radiotherapy is appealing, but these patients should also be preferentially included in a prospective trial. Traditionally, the local ablative therapy, surgical or radiotherapy, have been limited to palliation of symptoms in advanced lung cancer. Several retrospective studies suggested that using local ablative therapy for oligometastatic disease could offer good local control of the disease and improvement in the terms of progression-free survival. This is the old role of surgery or the usual role of surgery in stage 4 lung cancer. In recurrent pleural effusion, can be managed by pleurodesis. Preferred sclerosing agent is talc, which is more effective than bleomycin and tetracycline. And again, thoracoscopic insufflation is more effective than talc slurry sclerosis. Again, surgery might be necessary in cases of significant local complications related to the primary tumor or the metastasis, like abscess, uncontrolled massive hemoptysis, spinal cord compression, or pathological fracture. These are the areas which usually surgery came in stage 4 lung cancer. The contralateral single lung lesion, it's always a special situation. If it is, in most cases, this should be considered as synchronous secondary primary tumor and treated, if possible, with surgery and adjuvant chemotherapy if indicated, definitive radiotherapy or chemoradiotherapy. In patients, again, stage 4 with brain metastasis, if you have a single brain metastasis, can be treated either by surgery or stereotactic body radiotherapy, what they call now stereotactic radiosurgery, with equal results for appropriately selected patients. Patients with more than one lesion in the brain are evaluated according to their physical status. They are classified into class 1, 2, or 3 according to the physical status. The standard treatment for class 1 and 2 patients with multiple brain metastasis or more than one brain metastasis is whole brain radiotherapy. Stereotactic radiosurgery is preferred treatment for 2 to 3 brain metastases. And adjuvant whole brain radiotherapy decreases the brain relapses but has no effect on survival. These are some publications which appeared recently talking about the management of oligometastatic lung disease. This one was published in 2010. Following surgical resection, the overall 5-year survival rate is about 21% for patients with ipsilateral nodules. Patients with selected brain metastasis patients with resected brain metastasis achieve 5-year survival rates between 11 to 30%, and those with adrenalectomy for the adrenal metastasis achieved 5-year survival of 26%. Another one came out in 2016. In a highly selected subset of patients with oligometastatic lung cancer will be cured after all sites of established disease, primary and secondary, have been eliminated either by surgery or radiotherapy. That is the curative intent. And they found that the N2 disease was found retrospectively to predict the poor prognosis in this group. The 5-year survival was 4% in N2 positive patients compared to 31% in N2 negative patients. And so, the limit for the use of curative intent local therapy to oligometastatic lung cancer patients confirmed to be N2 negative. Another one, all synchronous metastatic lung cancer cases are evaluated by invasive mediastinoscopy or invasive mediastinal staging. 21 patients without N2 disease underwent curative intent treatment, while 13 with N2 positive disease treated palliatively, and they found that the N2 negative patients that had a superior 5-year survival, 58% versus 0%. This paper evaluated patients between 1997 to 2009, with 99 patients underwent complete solitary synchronous lung cancer metastatic resection. The overall 5-year survival was 38%, a significantly longer survival observed in patients without N2 or N3 disease. In patients with solitary metastasis in the ipsilateral, not the ipsilateral, in the ipsilateral lung or the contralateral lung, the 5-year survival rate was 48 and 23%. So, to conclude, Patients with metastatic lung cancer are a heterogeneous group despite of all being characterized as stage 4. Traditionally, local ablative therapy, surgical or radiotherapy have been limited to palliation of symptoms in advanced disease, in advanced cases. Oligometastatic is a disease with low metastatic burden and limited organ involvement. Metastatectomy for synchronous oligometastasis can be performed in selected patients. It appears reasonable that such patients should be considered as surgical candidates if mediastinal lymph node involvement is excluded. And due to the retrospective nature of most of the studies and most of the results, I think we need some prospective studies to shed some light on this issue. Thank you.
Thanks, Professor Ahmed Al-Nouri. And we will end this session and invite the chairpersons of the next session. Thanks.
سوري حصل في بس غلطة بسيطة. احنا لسنا في one topic, another topic. Optimizing the surgical management of early stage non-small lung cancer. عبد الرحمن. أستاذ عبد الرحمن تفضل.
Thank you, Mr. Chairman. I would like to thank the organizing committee for inviting me to give this lecture about optimizing therapy in early stage non-small cell lung cancer. Lung cancer is the leading cause of cancer-related mortality. It's responsible for about 28% of cancer-related mortality in comparison with other tumors. In contrary to most of the tumors, usually lung cancer present by late stage. As we see, 77% of patients with lung cancer present with early stage and only 23 present as early stage in spite of all screening program running. This is the new TNM staging system. The difference in early stages is that divided the T1 tumors by 1 centimeter. The tumor less than 1 centimeter is T1A, from 1 to 2 centimeters T1B, and T1C from 2 to 3 centimeters, because there is survival difference in each centimeter increase in the size of the primary tumor. What about the definition of early stage lung cancer? By early stage disease, we mean stage 1 and selected patient with node-negative stage 2A disease, while locally advanced disease is stage 2B, started from stage 2B and stage 3 disease. We have a very good survival, 5-year survival for patients with early stage lung cancer, ranging from 60% to 92% for patients with stage 1A disease. It seems that the T category in TNM staging is the key for decision making in managing patients with early stage non-small cell lung cancer. These are the questions we are going to answer during my presentation. Is there any need for staging of the mediastinal patient with early stage disease? Whom do we stage? What group of patients we are going to stage? Open versus minimally invasive surgery? What is the extent of resection of those patients, either lobectomy or sublobar resection? If sublobar resection, what kind of sublobar resection? Segmentectomy or wedge resection? And what about the incidence and risk factors for tumor recurrence in patients with early stage disease? Regarding the mediastinal staging, one of the investigators in 2009 reported that adenocarcinoma patient without mediastinal nodal involvement in CT scan of the chest, tumors larger than 2 centimeters and high level of carcinogenic antigen, there was incidence of 43% of pathological nodal disease in the mediastinum. Another investigators during doing systemic mediastinal dissection found 13% of the patients out of 524 patients having pathological M2 disease in spite of negative mediastinum by radiologic staging. The incidence of M2 and M3 disease in patients with adenocarcinoma smaller than 21 millimeters and squamous cell carcinoma smaller than 31 millimeters is 11% and 2.3% respectively. This means that we have 4 times increased incidence of lymph node metastasis and adenocarcinoma compared with squamous histology. The predictive risk factors for mediastinal nodal metastasis in patients with stage 1A disease, they found that older age
high level of carcinoembryonic antigen, 2 centimeter size of the tumor or more, or the consolidation tumor ratio of more than 89%, when these 4 factors collectively present, there is incidence of 33.8% of metastatic nodal metastasis in stage 1 disease. The next question, whom we are going to stage? We have to stage all patients with central tumor, even if the mediastinum is negative radiologically. Tumors larger than 2 or 3 centimeters, even if they are peripheral. N1 disease by PET-CT. Lymph nodes more than 1 centimeter in shortest diameter. Positive lymph node by PET, even if they are smaller than 1 centimeter. And the last is low standardized uptake value of the primary tumor in the setting of normal mediastinum. We all know that surgery is considered the gold standard for treatment of early stage lung cancer and some patients with late stage disease or locally advanced disease. Because surgery leads to complete eradication of the primary tumor and the draining lymph nodes, accurate pathologic staging, wide safety margin, proper planning of post-operative therapy, and provide adequate material for tumor subtyping and genetic studies, and proper evaluation of the prognosis of those patients. The next question is comparing open or thoracoscopic surgery. These are the topics that we have to compare: oncologic safety of minimally invasive morbidity and mortality, survival, cost, benefit, hospital stay, and functional outcome. When comparing vasculectomy versus thoracotomy, this study included about 400 patients in each arm. There was 1 post-operative death in each group, and there was no survival difference between the patient who underwent vasculectomy compared with open technique. However, fewer complications in relation to patient with video-assisted thoracoscopic lobectomy. A patient undergoing VATS lobectomy demonstrated 2 days shorter length of hospital stay in comparison with patient with open thoracotomy. What about the cost? They found that the cost of open surgery is higher by $2,000 in this study. This is because those patients have a longer hospital stay than patients with minimally invasive surgery. However, both groups have had good quality of life and was not statistically different at the late time, even after 1 year after surgery. We all know that surgery is now increasing and more practice all over the world, which since started in the year 1997. More recently, there is what we call RATS, which is robotic assisted thoracoscopic surgery. This is considered safe, applicable, and associated with shorter hospitalization of the patient compared with open surgery. Also, the number of lymph nodes retrieved by this surgery is acceptable and considered oncologically safe in patients with early stage disease. However, it needs further study regarding the post-operative pain, respiratory function, and quality of life, but robotic surgery is about 2,000 euros more expensive than VATS surgery or open surgery. The other question is about the extent of resection in patients with early stage disease, whether lobe lobectomy or sublobar resection, whether wedge resection or anatomical segmentectomy. These are the different definitions. The first one is wedge. It is a non-anatomical resection of part of the lung, while segmentectomy is considered anatomical resection, including segmental artery and segmental bronchus of part of the lobe of the lung, and lobectomy is removal of the whole lobe of an ipsilateral lung. And this is one of our patients, but actually this segmentectomy is done for metastatic disease rather than primary lung cancer. We have to identify first the segmental artery, the segmental bronchus, and then we have to cut the lung supplied by these structures. In comparison to lobectomy with sublobar resection for stage 1 lung cancer, there were 137 patients with tumors smaller than 2 centimeters and more than 150 patients with tumors between 2 and 3 centimeters. For small tumors less than 2 centimeters, there was no difference in survival between lobar and sublobar resection. However, for larger tumor, the median survival was significantly better for lobectomy compared with sublobar resection, which is 70 months versus 44 months with a significant p-value. This is a recent meta-analysis published this year comparing segmentectomy versus lobectomy for radiologically pure, solid or solid dominant stage 1A non-small cell lung cancer. They found 7 eligible studies, including more than 1,400 patients. For recurrence-free survival, the patient with segmentectomy group had a risk of recurrence of 1.46 times greater than those of lobectomy. However, for patient with stage 1A disease with tumor smaller than 2 centimeters, there is higher incidence of local recurrence, which is 1.8 times greater than those treated by lobectomy. The combined hazard ratio of the 6 studies is 1.5, meaning that there was no significant difference in survival, in overall survival between patients doing segmentectomy compared to lobectomy group. Regarding the perioperative mortality of sublobar resection versus lobectomy, this is a randomized controlled trial, is a multicentral international phase 3 trial for patients with stage 1A tumors. They concluded that the perioperative morbidity and mortality are nearly the same for those patients who underwent lobectomy or sublobar resection, and concluded that perioperative morbidity and mortality did not seem to be different between lobar and sublobar resection in physically and functionally fit patients with clinical stage 1A non-small cell lung cancer. What about another meta-analysis published? It's included a total of 9 studies, including more than 2,000 patients. There was no obvious difference in local recurrence in the subgroup analysis between segmentectomy and lobectomy. Sublobar resection was not associated with significant negative impact on distant metastasis or local recurrence. So this current meta-analysis suggests that segmentectomy had a comparable oncologic efficacy to lobectomy for solid dominant stage 1A disease. Regarding sublobar resection, how to choose whether lobectomy or sublobar, whether segmentectomy or wedge resection? The mean number of dissected lymph nodes in segmentectomy group is much higher, and the segmentectomy was associated with significantly better cancer-related 5-year survival in patients with stage 1 compared with wedge resection, which is 71 versus 48%. Wedge resection is also associated with significantly increase in the local recurrence compared to segmentectomy, which is 55% versus 16% for segmentectomy, and they concluded that segmentectomy is an acceptable alternative to lobectomy and not wedge resection in fit patients. Is wedge resection equivalent to segmentectomy? This is the question should be answered. Sublobar resection is done for those patients with cardiopulmonary comorbidity, although the resection-free margins can be achieved in all patients, but wider margin can be achieved more in patients with segmentectomy compared to lobectomy, and also there is a larger number of lymph nodes can be dissected. In spite of all that, there was no difference in overall survival or local recurrence or distant metastatic disease between segmentectomy and wedge resection. Sublobar resection do have a role in selected patients. In patients with poor pulmonary reserve who cannot tolerate lobectomy, also sublobar resection can be considered in patients with metachronous or synchronous primary lung cancer, and there was no difference in survival compared to lobectomy. Some patients with evidence of less aggressive lung cancers, namely minimally invasive adenocarcinoma and adenocarcinoma in situ. New evidence suggests that it can be done for patients with low tumor uptake by PET-CT, for small-sized tumor with lipidic histology or pure ground-glass opacity of more than 50% associated with similar survival to lobectomy. What about the definition of recurrence? Recurrence of the disease at the site of the resection margin is considered local failure. However, mediastinal hilar supraclavicular is considered regional failure. All other sites of recurrence are called distant failure. What about the high-risk group for local failure in those patients with early-stage disease? High-risk patients who represent at least 10% of the whole series, and they have higher incidence of 5% incidence of local recurrence above the comparison group. Patients with tumor larger than 2 centimeters with visceral pleural invasion, they found that they have 10% local failure compared with 4% in patients with low tumor size and no visceral pleural invasions. Other risk factors for local recurrence is parietal pleural invasion, patient with high lymph node metastasis, high-grade tumors, non-anatomic resection, lymphovascular space invasion. At the present date, where this is the conclusion, the standard operation for patient with lung cancer is lobectomy and mediastinal lymph node dissection or sampling, or systemic sampling. However, segmentectomy can be an alternative in selected group of patients. Minimally invasive resection is advisable if applicable, better tolerated by the patient, and has the same oncologic outcome. Several randomized trials underway to determine whether limited resection can provide at least an equivalent prognosis to patient with a lobectomy for early stage lung cancer. Limited resection is routinely used for patients with lung cancer with limited pulmonary reserve or other comorbidity. Lobectomy is the preferred surgical technique for high-risk patient for local recurrence. Lastly, you have to discuss with the patient the different alternatives of surgery and other non-surgical options and guide him to choose between them. Thank you very much.
Thanks, Professor Abdurrahman Muhammad. And this is the end of this session, and we invite the chairpersons of the next session. Thanks.